First, Dr. Salama, I want to say thank you.
You're welcome.
Thank you for taking time. I know I actually appreciate your skepticism in the beginning. Who's this guy calling me, asking me to do something? I know how valuable your time is. So the fact you'd hop on, I want to say thank you.
You're welcome.
And I think you know why I invited you. I hope you do. And if not, let me explain. When I asked Dr. Ratana, who's part of Dental XP,
Yes.
and is a friend of yours,
Yes,
I asked him, I said, look, I really, I told him the spirit behind what we're doing. Let's empower the patient. This is literally going to be non-commercial. I'm taking my vacation time. I'm doing all that so that it has a purity of heart and spirit to do this. Who would you recommend that's of that same educational, cares about the patient, really will shoot me straight? I don't want a bunch of BS. Somebody that will actually really tell me how it is. And he said, well, I don't know if he'll do it, but here's where I would start. And so that's how I came to know you. And so our first conversation, I really didn't know much about you. Really didn't, except that you were recommended and I trust him.
Sure.
I've gotten to do some research on you, and you've had a fairly successful career. So congratulations.
Thank you.
On that.
Thank you.
It's not easy in the dental game to do what you've done.
Sure.
And so would you do me a favor for the patients before we hop in there and start sharing about some of the wisdom you would like to help empower them with? Can you share a little bit about your background? Who is Dr. Salama?
Sure. Well, I'm an immigrant. I was born in Egypt and moved to the United States when I was just 3 years old. I moved to Brooklyn, New York.
Okay.
I did my training at State University of New York, Binghamton, upstate New York. And then I did my dental training, undergraduate and postgraduate training at the University of Pennsylvania School of Dental Medicine. I got my DMD degree, and then I went on to do a combination specialty program in both orthodontics and periodontics. And I also spent time at the Brandemark Implant Center at the University of Pennsylvania. After that, I decided to come down to Atlanta, but retained a faculty position at the University of Pennsylvania, which I'm happy to say I still do as a visiting professor. Also have had other professorships at Augusta University and also down at Nova Southeast University in South Florida. But I've been a clinician all the way through True and True. I joined this practice because it was at the time filled with what I would say leaders in my profession, people that I only dreamed of practicing with, people that I've read their books and watched their lectures, and then they asked me to join them, and it was like, am I really being asked to join the New York Yankees of dentistry? But I got that opportunity and I jumped on it. A young man from the Northeast coming down to Georgia was challenging in the beginning, but I love it down here. Very friendly part of the country, great people. And this practice really taught me a lot about life. The people in this office have been with me my entire career. My young ladies that you may have just saw in the window there have been with me 28 years.
Yeah.
Both my surgical nurses, my orthodontic assistant, 25 years. So we have a lot of people here who've been here, they're family, when they've been with you that long, longer than my wife. Mm-hmm. So it's become a family here. We also take a lot of pleasure and I would say pride in the fact that we're all educators. Dr. Goldstein, who is the founding and originating partner of this office, and his father opened this office in 1929, so it has quite a legacy.
Wow.
So Dr. Goldstein would always say, it's not good enough that I got you from a great program and you've been well trained. You see several specialists in this office, prosthodontists, oral surgeons, orthodontists, periodontists. But he would say, you need to teach. I need teachers here too. You need to give back. I want people who are going to be part of dentistry, part of the profession, not just live off the profession. And so he would, I would say, give a nice nudge, a push for us to write articles, to write chapters, to do clinical research, to benefit the entire profession at large. And that eventually led to the new group of dentists that we see here. As we got older, we had to replenish Team Atlanta Goldstein Salama needed new blood. And now we have Dr. Tadros, Dr. Silva, Dr. Paranos, a new Dr. Salama, Dr. Tony Salama, my niece, who's a periodontist.
Really?
Yeah, so
that's cool.
She's part of the practice now. So we also, in mid 2000s, we decided the world was changing, and it went from analog to digital, and education was changing. So how do we stay connected with dentists around the world? How do we educate the person who can't travel to come see us? And I'm very proud to say that we started the #1 online dental education network in the world, dentalxp.com. We were the founders of the company back in 2006. It was an idea. In 2009, it was launched, and we're now going on our 11th and 12th year. We have over 225,000 members around the world. We've educated quite a few dentists through that medium. So we've done it through lectures, live meetings, academy meetings around the world, traveling. I've been to 6 continents lecturing. So has most of my partners. But also through Dental XP, I've touched way more people than I ever could have done it through lecturing, doing that through the digital media that we now using in Dental XP. So it's been a big part of our office is to give back to our profession, to teach our colleagues how to do these procedures. Dentistry is changing at an alarming pace, as is most parts of medicine. Technology changes so fast. So how do you stay on top of it?
Current, yeah.
If you're waiting for the periodicals, I can tell you that it takes me, by the time I write the article, submit it, it gets refereed, you're already 3, 4, 5 years after a new innovation. With Dental XP, I can start doing something intriguing and share it with an audience in 6 months. So people are getting the material quickly, fast, and then we can spread the word through other networks and social media. So I have a much larger circle of friends in the world because of Dental XP than ever before.
There's 2 things I want to touch on before I dive more into Dental XP. I've learned in doing a little research on you and you bringing up your niece, Dr. Salama.
Yes.
There's a couple of Dr. Salamas in the game.
My brother, Dr. Henry Salama, who worked with us, traveled back and forth from Philadelphia for the better part of 15 or 16 years.
Wow.
So he has
That's
an
so
office
cool.
in Ventnor, New Jersey, lives in Philadelphia, but would come down and practice with us 3 days a week and then 2 days, and eventually, after that longer period of time, it wears and tear on you is a little bit large. So he's still a part of our team from an educational standpoint, still participates in dentalxp.com. He's no longer practicing with us like he did. He stopped doing that about 3 or 4 years ago.
And if I remember an article I read about you, he was one of the motivators for you to get in this field, or there was a doctor's brother, or
no, there was my brother. Henry is older than me, and he was at the University of Pennsylvania finishing his program in periodontal prosthesis, a dual specialist. So we both are dual specialists, trained at the same university. But I ended up with a problem with a tooth. I was an undergrad. I was studying biology. I have a degree in biology at Binghamton and State University. I had a tooth problem, so I drove to Philadelphia and saw my brother while he was part of the program. Ended up needing a root canal and a crown, and my brother and one of his partners, who's an endodontist, treated me there, and I got to see the school. And up until that time, I was pre-med. I took both my dental boards and my medical boards because I was really not sure which way to go. So it only happened after I saw my brother. And then a short time after that, I got sick. I had an illness and I ended up in the hospital for several days. Oh, no. Those 2 experiences probably led me to dentistry. The positive experience I had at the University of Pennsylvania with my brother, being treated there at the school by graduate students, and being ill and being at a city hospital just made me feel that the style of medical care would be mostly in the dental field, and I went in that direction, and I think I made the right choice.
Yeah, that struck to me about your story is I mean, this is a family affair, and
It is.
and that's cool. I mean, that's something, and I guess your story about moving on to Dental XP when. You said you originally had that vision back in '06, and then it came to fruition in '09, and how you met a patient, or there was a patient that was a web developer, and you shared your vision, and he helped you kind of put that together. Am I right on that? And so,
yeah, we actually went to them and said, actually the story started in a swimming pool. Had my son, my second son was born. I looked up, at the sky. So my son, my oldest one was 3 years old, saw a plane overhead, and he said, Daddy, in the plane, so which I was in a lot, going on planes a lot. My brother was visiting, who's now the CEO of Dental XP. He's not a dentist. My brother Eddie, and at that time he was like, it's got to be a better way. There's internet at the time, and there was no high speed, and it's back in the day. And he goes, why can't we just take this to the digital media, and therefore you can contact a lot more people, you can do a lot more teaching, be more effective for the rest of the world, without having to leave your house as much and getting on that plane that your son just pointed to. And I was like, yeah, but it doesn't exist. He says, well, why don't you make it exist? So we started playing around with the idea, but around 2005, 2006, we had a couple of young men who were patients of ours who were from Georgia Tech, who were computer engineers. And we said, hey, what do you guys think about this concept, this idea? And they were saying, hey, I think we can put it together for you in return for some of the dental work they were getting. And so it was a barter. But we put it together. They were a very integral part of the early days of Dental XP. They helped create the software and hardware that we currently use. It's been modified, obviously, and updated. But that was something that really led us to be able to find our way, what we're going to do. In the beginning, it was mostly interviews and very little content. We didn't know how to store it in the cloud and all the other things. So, today Dental XP is an older, more polished version of a little idea that grew out of a swimming pool in 2003.
And a father's heart wanting to be with his son.
Yeah, and a father wanting to be with his son for sure.
That's cool.
Yeah, I think so.
It is, and I hadn't heard that part of it, and I'm glad we got to capture that. Okay, so the spirit behind Dental XP and your heart to help educate it's amazing. I didn't realize why Dr. Ratana would suggest this, but it really makes sense now. Our heart to take that level of education towards patients. Now, my question for you, I think I shared with you on the phone, and maybe in the invite I sent you. I'm like most all on X patients in that I have a history of some dentists in my background that have been less than stellar, less than, and so, and because, I mean, the smile, I was talking about it today with one of your patients, Byron, where we were talking about just how intimate and how personal. There's nothing else like a smile. There's nothing elective.
It lights up a room.
It does. It can change a person. And I've seen it. I've tried it, of just how you can go and you smile at somebody and their whole disposition can change. And that power that you guys have is very powerful.
Well, psychologists have confirmed that. They talk about laughter. They talk about smiling, even in the mirror, trying to smile. But the fact is, for many people, what they see in the mirror is not how they envision themselves. They look at it and they want to smile, but what they see is something that is something they're not proud of. Maybe it was neglect. Maybe it was economics at the time. Maybe their parents couldn't have helped them get the right treatment. And they are, I wouldn't even use the word shy. They actually feel remorse, regret,
shame,
shameful. Yeah,
shame.
And it's a horrible way to feel, because what happens when you remove that aspect of somebody, you really are removing half of their facial structure and features and the muscles of smiling. You have certain muscles around your lips that impact your lower facial third. So it's like putting a mask on, for lack of a better term. I mean, if you can't smile, people aren't seeing the whole you. So although people think of it, and it is obviously very important from a health standpoint, there is a significant part of it that is psychologically based. And you can change somebody's demeanor, the way they emote, the way they reflect their emotion, the way they see themselves, self-confidence. And I've seen that on young patients just from straightening their teeth with orthodontics. And I've seen it with older patients when they have lost, for whatever reason, all their teeth, or their teeth are going to need to be removed, and they are just destroyed with the fact that they may end up with dentures. And full arch and all on X therapy gives patients a second leg on life. It allows them to say, hey, you know what? We can erase all that stuff in one shot, and we can give you a whole new slate. We can wipe it clean, take away all that disease, all that discomfort, all that shame, and we can start anew. Yep. You know, people always talk about, you know, New Year's resolution. Now, this year I'm going to lose weight. This year I'm going to get in shape. This year I'm going to learn a language. But how about this year I'm going to learn to smile again. I'm going to get healthy again. I'm going to have a smile that I can be proud of, so that I can smile at my wife, my significant other, my kids, my family, at work, you know, to my patients, for me. And realizing that that is available, that's something that's powerful to me. And that's what helps us feel good about coming to work every day.
Sure.
Because what I've seen when we do, out of all the work we do, and we, you know, because we're like a little dental hospital here, we have several different specialists, 7 dentists, a few surgeons, 3 surgeons, 2 prosthodontists, 3 prosthodontists, 2 general cosmetic dentists. So we have the whole gamut of people here, including anesthesiologists, and we have an outpatient center, and we have ceramists and an in-house lab. The fact is, we work as a small dental hospital. It's not a dental clinic. We have all the specialists come on board to work with one focus, and that is to try to do the best we can to transition a patient from infection, disease, and pain to health, smile, and joy.
And it happens with the all on X so fast.
That's the most amazing
It really is, because orthodontics, it takes a while. And if you're going to even do veneers, that can be kind of, but still they don't have the health issues typically. It's more just cosmetic. I mean, that's what most people don't understand, and that's where my passion. My mom had her upper and lower done. She spent 20 years in dentures, just even the shame of having dentures and all this stuff. And then yet all of a sudden, for her to get that upper and lower and to see that it's health too. It's not just ego. You know what I mean? Like veneers are great. I mean, I'm gonna do some unique stuff to my bottom row because I only had to have my top done. But the health side, the functionality, being able to eat and being able to, you know, I mean, I remember when talking with one of our clinicians that we did work with, and he showed me some before and after pictures. And I noticed, even though it was that shot, you know, the shot of just the face, but the skin looked different.
Yes.
And I was like, wait a second.
Bite opening. When people lose their teeth, what people don't understand, a lot of times they wear down their dentition, so their face overcloses. Huh. So think about when you're replacing a tire on a car. You need a jack.
Right.
You jack the car up so you can take the tire out. So think about, in your mouth, you basically had a slow release of air causing a flat tire.
Whoa.
So that you, by opening the bite, all of a sudden certain wrinkles go away, your face looks fuller, your face has more longevity, looks more youthful in appearance. So we can change the lower third of the face, both in fullness and in height, immediately. Plastic surgeons couldn't do that.
No.
And think about what you said. Orthodontics can take sometimes years. Even if you have plastic surgery, you're going to have to heal. The stitches have to be removed. It takes a while. If you look at other areas of self-help situations. Go on a diet. You're not going to lose 30 pounds in a day, right? I hope not, right? So things take time. You're going to get in shape. You're not going to go to the gym, lift weights one day. You're going to have to do it for a while. All on X. I want you to think about this for a second. A patient could come in after years of neglect, years of contemplating, should I do it? I don't know enough about it. Can I afford it? Do I really want to go through all the discomfort, the pain, whatever things they talk themselves out of? And in one day, they can go from infection, pain, and something they're not proud of, and immediately, in one sitting, in one day, have a new set of teeth. Even though if they may not be their finals, they are functional and beautiful, and they done in a day. And that's why when we started to promote our concept, we said One Day Implants became our website, onedayimplants.com. And it really is a website, as opposed to what we were talking about, dentalxp.com, which is to train dentists. Even though, believe it or not, there are patients who come to dentalxp.com.
Really?
Yeah, there are. Patients come and they'll use alias names and they'll act like they're dentists, but but some of them will say, I'm a patient looking for this kind of treatment. I live here, and they're looking for referrals from this community, online community of dentists who've decided that education is important. But the point is that with onedayimplants.com, we really did it for the patient. We put a series of common questions they should ask themselves. We've answered it for them. We expose them to the process. What will day 1 look like? What will day 2 look like? What will day 3 look like? You'll come for a consult. We're going to take a cone beam CT. We're going to take a scan of your mouth. We're going to take photographs. So now the patients understand when they come in, because if I go to a doctor, I want to know, what do I expect that day? Are you just going to look me over, or are you going to actually do something? Should I be prepared for x-rays? Should I be prepared for manipulation? Are you going to
Should I be prepared for a needle?
Yes, a needle in the leg. Am I going to get a medicine?
Right.
So the same way that happens with medical doctors, that also would happen with a dental patient, especially all on X, because it's very sophisticated work. It's not something for the faint of heart or a minimally trained person. And our best patients are the patients that want to be educated. Believe it or not, if I have a patient come in and say, I heard you were great, Dr. Salama, you come very well recommended, and I trust you. And the first thing I would say to them is, I really appreciate that, and I thank you for the trust, but I still need to educate you. Because an educated patient is the best patient I can have. So my goal, and the reason I loved when you came to me and asked me to do it, and you did research on me and I did some research on you, I wanted to see what you were really looking at, what you were thinking about doing. And the process of educating patients was very critical to me. And it was obvious that's what your intent was. So for me, what I would tell patients who are considering this kind of care, this is very important. Unlike our medical doctors who are subspecialized, even in dentistry, a general practitioner can do any type of dentistry. They can do oral surgery, they can do periodontics, they can do endodontics, they can do orthodontics. They're not limited. They can do anything they want. Yeah. The difference between a specialist and a non-specialist is the fact that you have extended training in the particular discipline. Now, they can get this out of school. Dental XP is one way of doing that. We offer programs to try to assist people in getting some of their education outside of a classic graduate program. But the fact is that they're not specialized right out of school. This takes experience and it takes education to do it. And it takes certain factors. Diagnosis is key. You need to have a CAT scan machine. They need to understand how to treatment plan in 3D. So we have software that we use that takes the information about your jaw and allows us to actually do the surgery on a computer screen before we actually do it in the mouth. And I can show the patients that in different colors, in 3D, in their mouth. Think of it taking a test drive or a flight simulator. You wouldn't get in a plane with a person who never flew the plane for a couple hundred hours on a flight simulator
Right.
before you got up in the air, right?
Right.
So why do that with All On X? Even if you go to somebody who's not a specialist, they need to have had the training. But I would ask the question, where did you get your training? If a surgeon, will say that they went to 4 years, 3 years, whatever programs that they were in, they have training in oral surgery, in periodontics, in implantology. General dentists may have had training at an academy, may have had training with CE courses, that they were trained in this discipline, because this discipline requires multifaceted training. You need to know the parts, you need to know the anatomy, you need to know how to do the procedures, you need to know the surgery, you need to know the restorative dental part, actually how to make the part that connects the implants to the teeth that eventually go in your mouth, and then the laboratory part. And all this with digital technology. There's digital dentistry now, where we are fabricating your teeth utilizing 3D printers and 3D milling units.
So cool.
And we happen to be, and I showed you earlier in our lab, we have two ceramists who are, again, also incredibly well trained out of UCLA, with one of the best people in the world, a ceramist and laboratory technician to train them. But the fact is that we have several 3D printers and 3D milling units in the laboratory. So the materials, zirconia, monolithic zirconia, these materials, they are only been around for a decade or so. They haven't been around for 50 years. So people have to be involved in understanding the materials, educating themselves.
And an ongoing basis.
On an ongoing basis. But also, who's the team? I would ask, if I went to see somebody, not only about their training and their experience in this area, I would also ask them, who's your team? I want to know who the team is. Some people will refer you. Maybe you do the surgery in one office and you do the restorative dentistry in another office, and then that restorative dentist sends your case out to a laboratory who's now a third team member. That doesn't even include your hygienists and your staff and your nurses. For us, think about it, even when I said we're a dental hospital, we have an outpatient center. We have an anesthesiologist who makes sure that you're comfortable, sedated. We have a prosthodontist. We have a periodontist, implantologist, surgeon. We have laboratory technicians. We have all the technology, the 3D printers, the milling units. We have the scanners. We have the intraoral scanners, the CT scanners. And then, of course, we have the hygienists that then have to follow this work, and they also have to be educated. How do you maintain it? Would you buy a Ferrari or McLaren if you didn't know where to take it when it needed an oil filter change?
Yeah, would you just go to Quick Lube?
Yeah. My point exactly. Would you just do that?
No, at all.
And that would be, that's why I say to people, the first part is the power of All On X, and I wanted to get to this, so I'm going to just do it now because you got me going, and this is important. I hope this won't get edited out.
Okay.
It's not just about that first day. You get your teeth and you're ecstatic, and of course there's going to be some touch-ups done because it's the first rendition of your new set of teeth. But even after the final is done, long-term maintenance. How long are these things lasting? Are they being done correctly in the lab? The dentist has to direct the lab tech. You get only what you understand enough to direct them. Otherwise, they're going to give you whatever they see in their vision. And then it may not be cleansable. It may not be hygienic. It's not the patient's fault because now they can't clean under it. So now you spent all this money and you have a device that's been put in your mouth. It's a medical device. This is not just a set of teeth. It's a medical device.
That's right.
Right? We have to understand
Not
this.
just a denture.
No, it's not a denture. It's a medical device. It's connected to
Great
your jaw.
Great point.
And you're now not able to clean it, or you haven't been instructed on how to clean it. Or, as you said, maintenance, they don't know who to go to, or the hygiene team hasn't been educated on how to take care of it. So now they can't help you maintain it. As you said, taking a Ferrari to Jiffy Lube, it's just not going to work.
Nope.
So the car breaks down. Is it the car's fault? Is it the mechanic that built the engine at the Ferrari factory? No, it's that you didn't know how to drive the car, you didn't know who to send it to maintenance, and it wasn't done correctly. So this is I mention cars because people typically say to me, wow, that the cost of All Next costs about, my last car I bought. And I typically say, yeah, it does. And it probably will give you, hopefully, a lot more years and a lot more joy and a lot more pleasure. Or you can buy the car and then take out your denture and wave it to the people outside your window. So you need to understand that what we do is significant. It's a medical device.
It is.
It's a big expense.
It is.
Is it worth it? For sure. And then some. But if you want it to last, you got to know where to take it. You got to know who the people are who are going to do the work with the best materials, with the best lab, with the best team, with the best education.
Yeah. I mean, you probably listed off 40 things I want to touch on. Let's touch on one of them, and we're going to do it in reverse order just because it's fresh on my mind. Cost. I've one of the patients we interviewed, Byron was who I interviewed of yours today, was a rare example that he was blessed, truly blessed to find you first. Mm-hmm. I mean, that's not. I personally, with my mom, just because I wanted to make sure I went to Clear Choice. Mm-hmm. I went to Golpa. I went to Arch Point in Dallas. I went with her. I wanted to hear and see, and because you're right, it is a significant expense. And in this last conversation with the patient that we talked about, the one in Dallas, he was talking about how he went to places that were cheaper than where he ended up. Yep. And that was something that I wanted to highlight and help educate patients. And I do. I want you guys to know this. And for the record, I haven't paid you to do this. You haven't paid me to do this. Yes?
Not at all.
And so this is not an advertisement for Dr. Salama or any specific practice out there. This is good principle to use because this is an investment. This is something that if it's done right and it's done with the right team, just like Dr. Salama talked about, I hope we get a chance to kind of highlight this practice. I've been in a lot of practices, and this one is significant in size and in scope. This comes with an investment. They had to invest in this team and this talent. And so if you go to the cheapest place, what have they invested in? Again, Dr. Salama talked about, and you might have heard in some of our other videos, you just DDS out of school and you technically can go do this. Should they? No, they should not with advanced training, but you can do this with just a typical DDS degree. And I don't want to beat up on just that, but the investment that they make in their education, the continuing education, in their team, in their technology, in their materials, in their continuing education. Do they go to conferences? Do they invest in a Dental XP membership and really engage and take time out of their day that they could even be making money, if you will, to invest in their future? God, that is so important. So again, I really want you guys to think through the investment piece of it, because it is expensive, guys, but it's not its cost, it's its value that I would focus on. How much value do you get for where you go? It talks about a dental anesthesiologist, or do they just drop you a pill and wish you good luck? I've been in those surgeries, guys. I filmed one where guy's under conscious sedation, he didn't get knocked out, and it was one of the most nerve-wracking events of my life, and I'm in the room. So I didn't mean to go on that diatribe, but it is so important to know the not just the cost, but the value side of it.
I think that what you just touched upon is so critically important. Most people don't get that. So I applaud you. I applaud this whole concept because unfortunately there's nowhere for people to go to get educated. This is maybe going to become a vehicle for that. So for that alone, I applaud you, and I obviously have been motivated to participate in whatever way I can. Yeah. We do believe that the commitment is to make this affordable, but even to make it affordable it still has a cost.
Absolutely.
And the cost is significant. Therefore, there's a line that was once told to me by one of my former mentors. And he used to say to the patient, she says, well, I can't afford it. And he said, honey, this is my older guy. He could say honey back then. He said, honey, let me tell you, you can't afford to do it wrong.
That's what you can't afford.
You can't afford it, but you can't afford to do it wrong. Meaning that you better not have to do it a second and third time, because that's when enormous cost, not only money, but also in psychological element, the time in the chair, the healing, the scar tissue. So for us, we want to educate our patients. So become educated, ask about who they're using, what's the team made of, where do they get how much experience do they have, where do they get their teammates, what is their education. Yeah. There are a lot of good people out there. This is not only one person or one group that can do this. There's a lot of educated, great teams around the country, around the world.
Yeah.
But when you're talking about replacing teeth that haven't been there for 20, 30, 40 years, people suffering in dentures, could never go out and feel comfortable eating, and now they have teeth again. When you see people who are losing their first set of teeth and they have a second set that's now available, all on X is just a powerful.
So powerful.
One of the most powerful thing when you're talking about, we were saying that impact. When you see those patients after that first day, when all of a sudden they walk out and they have teeth that look good, that feel good, and they hadn't had it for all those years and they suffered, it has impact. So cost, I would just simply say be careful of limiting yourself to whatever you see on TV and thinking that's the only thing that you should be valuing, because you can't afford to do it wrong.
No, and I'm really grateful. There's a guy in our area, I'm not going to mention his name, but he advertises beat any quote by 10%. And I thought, okay, I know he's getting a lot of people, because people look, hold up, I'm going to step back, and I learned this the hard way. Why? Because I went, even though, like, the irony is, I went to Costa Rica to get my implant work done.
Right.
Why? Because I thought, man, if it's going to cost me that much money, I'm going to go on a vacation instead of giving it all to the dentist. That's my heart. Yeah, sure. That's where I was. And so
there's a lot of people like that. And I've seen people from different countries, Colombia, Mexico, Costa Rica, that have had their dental work done and then have to come back here. And I feel for them. I
have to do it twice.
Yes, of course. I commiserate with them. They come in tears. I spent this money I really couldn't afford, and now they have to find a way to repair it. And I try to do the best I can. Many times we try to discount our fees to a degree, but now they're paying for something again that they wouldn't have needed to. They have to go through the procedures again.
Right.
Implants, by the way, for people to understand that are watching this, I think is important. So I'm going to look at the camera this time.
Okay, please.
Implants can fail. They can fail just like teeth can if you don't take care of them and if it's not done well. Don't believe that just because they're using the same titanium screw that's going to be all that you're really paying for. You're paying for their experience, their skill, their education, their technology, their know-how, and the ability for them to maintain you. Also, when you're considering this kind of work, is to understand that you need to have a certain amount of bone structure in order for there to be implants placed. Without bone, there's no implant that can be placed to anchor the prosthesis. In the end, you end up wanting teeth in your mouth. And if there's not enough bone, we're going to have to find other solutions. Depending upon, again, the training and the experience level of the team, we either have to graft bone to build bone where there's no bone, maybe the day of the surgery, or if it's very severe, we have ways to use extraoral sources of bone anchorage, and we use a zygomatic
bone. Do you do zygomatic?
Yes, we do zygomatic.
You can do zygomatic.
Yes, we do. We can put bone. We can put implants in the cheekbones. We can put implants in the pterygoid plates behind the maxilla. We can use bone in the vomer process behind the anterior nasal spine. So we have
Wow.
other extraoral areas of being able to anchor implants for prostheses. And again, those can also be in most cases, I'd say the large majority, the high 90s, is receive teeth in a day.
And that again, any of you out there know that I'm not easily impressed. I don't, again, but to, when Dr. Salam is talking about zygomatic implants, when he's talking about some of the pterygoid and going back in there, again, I know way more about this than I ever wanted to know, but at the end of the day, that is not easy. That is so difficult. You're not just doing take out some teeth and zip in some screws. I mean, you have to angulate that, and they're long. I mean, when he's talking zygomatic, it is a very challenging process. And so, talk a minute about that. Why don't we spend a minute teaching a little bit about patience? Because my mom was one of those cases in that she, when you wear a denture for 20 years, you have the resorption, you have the bone. And I didn't know that the bone atrophies.
Oh, yes.
That it goes away. I mean, I knew it would go away, but I didn't realize it was from atrophy, if I'm even saying that right. But that, and so she was left with having to go way back up in here.
Yes.
Talk to me a little bit about that.
Well, when we lose teeth, most of the time what ends up happening, people lose teeth and they don't do anything in the areas where the teeth have been lost. So therefore, you have atrophy from disuse. But you also, when they lose all their teeth, they have a denture. The denture now loads on top of the bone for many years while you're chewing and functioning. And just like water hits a rock, can eventually make a hole in the rock, chewing on your bone and on your gums for a long period of time eventually causes the bone to resorb. It's a fancy word for melt away. And eventually all the bone that you once had as a teenager can be completely removed and resorbed over years because of the loss of the teeth. So we talk about alveolar bone, that's the bone surrounding teeth, and then basal bone, that's the bone underneath. And what I mentioned that is most denture patients eventually end up, because of the wearing down of the alveolar bone, the resorption and the atrophy, they end up on basal bone, the base of the jaw.
I never knew this. And I mean, I know about the periodontal ligament.
Yes,
I know about some
that.
of those, but I didn't know there's two different types of bones within this.
Alveolar bone is the bone that houses the teeth. So when the teeth are gone and you don't do
the hole, so when you pull it out and that socket,
there's a hole. That hole that holds the tooth is called alveolar bone.
Okay.
The bone below the root of the tooth is called basal bone.
Okay.
So imagine that you can lose all that bone until you're only on basal bone. And now, as you said before, some of the issues we have is the anatomy. The anatomy in standard dentistry, you're dealing with sinus cavities, maxillary sinuses, nasal floor. You obviously have a nerve that travels the floor of the mouth. You have a nerve called the mandibular nerve that it innervates your lip, and you don't want to have anybody drill into that area.
That's a big deal.
You don't want somebody to go up into your sinus or in your floor of your nose. You can cause problems. So knowing the anatomy, knowing how to build bone in those areas is very, very critical. Knowing how to make sure that you stay out of trouble as the person doing the surgery. We can grow bone today better than ever before. We can use growth factors. We can use your own bone. We can use synthetic bone. We can use processed cadaver bone. But there's some people who, because of their age or their medical compromises, just can't go through a lot of surgery.
Right.
And they just don't have enough bone for us to work with. We can then use, as we said earlier, extra oral sources like the cheekbones, zygomatic implants, pterygoid plates, which are behind the maxilla, vomer process, floor of the nose, behind the front teeth. These areas can be used to anchor implants that can then support a prosthesis in the same way. But as you said, that takes another extended amount of training. Why? Because you're dealing now with the orbit of the eye. You're dealing now with the sinus. You're dealing with a very long implant that's sometimes going to be 45, 55 millimeters long, not 10.
Right.
And you really have, arteries and blood vessels and nerves that travel in the pterygoid plexus. You need to know how to do these procedures. You need to have significant training in that. Not that it can't be done. It can, but they need to have the training. So those are available to you. If you're a patient that has no bone, if you went to a dentist, I've had patients come in and say, I went to somebody and they told me I'm not a candidate. And that's true. You may not be a candidate for conventional standard implants, but almost everyone we've seen, I'd say 99.9%, the candidates for different types of extraoral anchorage implants, whether there's zygoma, pterygoid plates, vomer, or even in the mandible, there are other ways for us to angle implants, anchor implants in the basal bone.
Okay, I've got, I respect what you've put together, what you're a part of, and your history. Let me ask you a question. What's your biggest failure? Out of all your dentistry, share with me your biggest failure, if you don't mind.
No, I would tell you, if you're talking about my biggest failure with a patient treatment.
Yeah, why don't we start there?
You know, my biggest failure will always be the fact that will never be, I would say just the opposite. My biggest failure will never be for lack of preparation. I think it's more important. So when I go into treatment, I've already done your surgery. I'm now getting a second or third time. What do I mean by that? In this office, we spend a plethora, probably as equal to or more time, working on the planning of the treatment than we do actually doing the treatment. Okay. So having said that, I look at the scan, I merge and stitch your mouth scan to the CBCT scan, and I then go into a flight simulator. And I do, think of it as an implant simulator. I do your surgery on the computer. I mean, completely, with the measurements, the angles, everything. I then work with my colleague, Dr. Tadros, Dr. Silva, Dr. Garber, and the laboratory technicians, Sean and David, and we base all of the implant placements on where we envision the teeth are going to be. Because if I place your implants and they're not where the teeth are going to be, it doesn't matter.
Doesn't matter.
Right?
You just got a bunch of screws in your jaw.
Just a bunch of screws in your jaw that they can't use.
Right.
So I need to work with that's why I said, who's your team? I need to work with a team who then can put those teeth that we're going to build, not the ones that are coming out, but the ones that are going to go in. And we need to plan the implants to be placed where the teeth are going to be. So that becomes a big part. The next part is three-dimensionally. We can print a stereolithographic model of your jaw. I can have your jaw in plastic, and I can actually do your surgery on a plastic jaw. So I did it on the computer. I did it on a plastic jaw. I have the teeth that are going to end up in your mouth printed and milled here in our own lab. I work with the team that's going to put it in your mouth. And then I walk into the surgery to do your procedure. I've done everything. I would have to fail 3 times. Because I'd have to fail in the diagnostic part, in the planning part. I'd have to fail on the computer. I'd have to fail on the stereolithographic model. And then you would figure, and that's why I say teams. When you work with a team, thank goodness the failures are very small. And I'll tell you, I'm going to get to where my failure is.
Okay.
Not going to lose that.
Okay.
But the reality of it is, I have so many different layers built in to where someone, even if it's not me, can see where the failure may occur. Oh, I see that on the scan. Oh, wait a second, I was drilling on the jaw. I can see where that's going to be a problem. Or the lab guys will say, oh, wait a second, Dr. Salama, if you push the implant in that angle, it's going to put pressure on the zirconia and it could be a fracture point. We need to segregate the implants by a little bit more distance. That's the experience of a team. So each member of the team then sees the layers. Think of it like an onion. You're peeling the layers back. And each person gets a chance to see the failure, see the potential failure before you end up in the operatory, in that chair, and we have the whole team in the surgical theater doing your work.
Right.
So I start with the fact that biggest failure for me would be I didn't spend enough time looking at the information. The information was there. My biggest failures occurred back in the 90s because I didn't have all this technology, didn't have all this information. So I would assume off of two-dimensional radiography, just panoramic films, PA films, that I could tell what was under the gum, what was under the skin, just by palpation and seeing a two-dimensional film based on experience. That's when you make your errors. So, biggest failure I was ever involved in was I was an educator at the University of Pennsylvania. I was a faculty member at the Perrier Clinic. And a patient came in and said the teeth were broken down. He said, I don't think these teeth are going to be good to support full arch of teeth. So he said, how about can I take them out and we'll then put in implants after she heals? Well, they made this assessment based on two-dimensional radiography. Regular films, dental films that you get every day, and cavities, periodontics, and a panoramic film, something you get for orthodontics. Took the teeth out, let the patient heal. Patient had a denture. They said they were only going to have the denture for a few months and then we'll do the implants. But when the patient came in and they made their incision to place the implants, there wasn't enough bone to place the implants.
Oh, no.
So you had to suture her up and put her denture back in her mouth and say, we're really sorry. We didn't know that you aren't going to end up with enough bone because we couldn't see it. We couldn't know beforehand because it was two-dimensional, not three-dimensional. We couldn't assess it in its full three-dimensional, realistic positioning. So what ended up happening is not only a very disappointed patient, but now a patient had to undergo bone grafting, sophisticated bone grafting procedures, had to go for a period of time without their denture so that the bone could heal.
Oh, no.
Yes, no teeth at all now. And then after all that heals, then have the implants placed and then have their teeth. And now you're talking about waiting more than a year
Oh, yeah.
to receive their teeth, maybe a year and a half. So that would have been the worst failure I was ever involved in.
Yeah.
And maybe the reason I say for me it was the worst failure is because as an educator, I didn't have the information to give the student better information. If I could have seen it beforehand, I would say, we got to be careful here, treating this patient this way and over-promising and under-delivering. Maybe that would have been a patient that today, if I would have known that, I'd say, not enough bone, so maybe we go to the zygoma, the pterygoids. Maybe we go ahead and consider vomer as an anchor source, anterior nasal spine. If we're doing that, we're giving the patient realistic information and they can make that decision. I've had some patients say to me, hey, you know what? I don't want, it scares me to think that you're going to place implants here and there. I try to explain to them it's nothing new. It's been around for a very, very long period of time. And if it's done by experienced teams, they work very, very well. We've shown you actually that scan that was on the computer screen earlier.
Yeah, I saw that.
That was a zygote and a pterygoid implant on one side. The other side didn't need it, but one side did. We're able to treat those patients without a year and a half of suffering, multiple surgeries. We can do it in what we call a graftless approach, meaning that we can do it without grafting, or we can do it with very little grafting.
Because grafting is, and that's something it's hard. I mean, I have a picture I'll show you where I had a pretty gnarly bone graft and my face.
Yes.
I mean, it swole up, and yet nothing like when I had the All on X.
Right.
The All on X was.
And that's something. Let's talk about that. I'm sure you're a pretty healthy guy. You look pretty fit to me, and you went through a bone graft and your face was swollen. And okay, imagine what it's like for an older patient, a patient who's phobic, maybe a patient who has other medical issues, blood dyscrasias or diabetes or things like that. Those patients don't heal well. So being able to avoid those types of sophisticated bone graft procedures avoids that kind of trauma. What we have seen is even in cases with very little bone, when we do all on X and angle the implants and give them the implants, or even with zygo and pterygoid implants, we hear patients come back because they're not being grafted with less swelling, with less post-operative discomfort. So when people say to me, oh, that sounds really painful, all on X, oh, you know what? That sounds really painful. What I tell them, surprisingly, patients tell me that they don't really feel the type of pain or discomfort or even swelling that they get from a standard dental surgical procedure. So in many cases, people most of the time are surprised. You spoke to Byron earlier. His wife, I don't know if he told you, eventually ended up having the procedure done as well.
Yeah.
So she saw him go through it. He did the upper and the lower. And then once we finished her work, she then said, hey, it went great. He wasn't in a lot of pain, wasn't very swollen. I want to do it too.
Yeah.
So now we have husband and wife who've gone through the full upper and lower all-on-X therapy. And they're, as you could have told from the interview, very, very, very happy. But I'm sure if you didn't know better, you would just say, that guy has a great smile.
That's it.
Good-looking guy.
I appreciate you sharing the failure, and I think, one of the reasons I asked the failure question is I noticed in one of your articles that you did. I mean, I really did some, once I found out that you got some street cred out there, you got a lot of it, a lot more than I thought. And so that's where I thought, all right, I want to really get to know him. And one of the things you talked about was failure and how important that is.
You grow from failure. But the most frustrating thing about failure is, like I said, you didn't plan. You plan for success and you equally plan for failure. So most of the time when people fail is because they plan. They don't realize they plan for failure, but they plan for failure. What do I mean by that? You get too comfortable.
Yeah.
You start to think you know it. You've done enough of them. But the fact is, there's every single patient that's ever sat in that chair, I've never seen one ever like the other, especially not with all-on-X therapy, especially not. Every single one of them is completely different. Some lose their teeth because they break them. Some lose them because they get cavities on all their teeth, decay. Some people lose it because of gum disease. Some people lose their teeth because of trauma.
Like cancer.
Or, God forbid, radiation.
Right.
So you have people losing their teeth for different reasons. Those reasons lead you to assess them differently. Their risk levels increase or decrease based upon how you use them. For instance, if I have a person who's a big truck driver, large masseters, crunches, how'd you lose your teeth? Oh, I broke them all. So am I going to put all on 4 on him, or maybe I'm going to do all on 6 or 7 or 8?
Right.
I need a couple extra implants to help me on this guy. Otherwise, if he broke his teeth, he can break my implants, break my screws.
And in that example, just out of curiosity, would you do a hybrid lower or zirconia upper so that there's not that much impact?
Sometimes what we do is we change materials. We always put them in a night guard. So always in a night guard. And we sometimes alternate materials. So we place them maybe zirconia on the top and maybe something with a different material on the bottom, or vice versa.
Yeah. Do you do that much different? I don't mean to interrupt you, but do you do it much where the zirconia is on the lower and a different material on the top?
No, typically we like to use zirconia on the top.
Yeah.
Because that's another thing people should know. Not all zirconia is the same. Everybody thinks it's like saying, you send overnight mail. People say FedEx, but
it's not like all wood is the same.
Yeah,
you got your oaks,
you got
your
maple,
pines,
you got your pines, right? So not all zirconia is the same, and not all of the technicians that work with the zirconia are the same. They also have experience levels, training.
Amen.
Our guys here, as I mentioned before, Sean and David were trained by Ed McLaren, who's used to be the head of ceramics and laboratory at UCLA.
Yeah.
So Ed's a dear friend of ours, and he trained these young men. They're brothers, which is great because you're talking about the family aspect. So I have my niece here, my brother worked here, so we like having people that have similar backgrounds, that enjoy one another, work another, and push one another to get better. One of the great things when my brother Henry was here, now my niece, I push them. I push her, and my brother pushed me, and Sean and David are in the back. They're not twins. They're younger and older brother. They push each other to get better. Hey, that's not good enough. You can do better. So one of the nice things about families can tell the truth to each other. They don't have to worry about sensitivities, right? Maybe too
You
much.
can hug. You can hug afterwards.
Yes.
But yeah, you can be blunt and bold.
Yes. I think this thing.
You're talking about the pushing and how, we talked about family, and that's what, you don't have to be as political. You don't have to dance, but I'm going to guess, just because I'm a lot like this and I can spot it when someone else is, you push yourself harder than you push anybody else.
For sure.
Where you are hard on, you don't rest.
No.
Don't just settle for, well, I've done it enough. So you push, and any mistake is a big deal.
Oh yeah.
And you will not let that, yeah.
Yeah, my girls will tell me I'll do 9 things perfect, and the 10th thing isn't perfect, and all I'll talk about
That's all you focus on.
is that 10th thing that I didn't do perfectly. But listen, you are right. I think that drives you. I think it makes people who they are. Those are the type of people that I would want working on me. What I would say is that all on X therapy for me has allowed me to work more as a team than any other procedure in dentistry. Because I need everybody working together. I need the anesthesiologist, I need the prosthodontist, the lab technicians, the surgeon, the hygienist. Everybody's got to be in it together, including the designer in the lab. I mean, people don't even talk about that. We have a designer who works in the digital dental part that actually helps construct the teeth and frame it within your face. So, you can say, to make a long story short, it's a long story. You're helping educate people. They're going to see this. Know who you're going to. Don't just focus on cost. Make sure that you get educated. Make sure they have the right technology and right diagnostic tools to work on you. Make sure they have a cone beam CT unit. Make sure that they're going to use some digital dentistry. Make sure they have an idea of where the teeth are going to be in the end. And in many cases, they may be able to perform a digital smile design for you, a smile rendition or a mock-up, to give you an idea of what it's going to look like in the end before you even get started. They can do it on a computer sometimes and simulate it. Yeah. If you do that, if you're involved from the beginning, I would tell you that All on X may be the most rewarding treatment you may ever have. Mm-hmm. And that includes, by the way, when people say, my facial plastics, my facelift, my liposuction. I will tell you, if you're anything like me and you like food, there's nothing like sitting around a table, going to a restaurant and enjoying, and hopefully after all of this virus and COVID thing is all gone, I think people are going to be, the first thing they're going to want to do is go sit around in a nice restaurant with their friends, smiling and eating.
With their friends. It's a communal gift where you can get new boobs, you can get a bigger hiney, you can get your face done. What does that do for the community side of things? A smile, where you eat, how you interact, it really is the most impactful.
100%. And one great thing about zirconia, which Marco maybe can touch on, we can bring him in, is that zirconia allows us to do it in the strongest material that we've ever had in dentistry. Yeah. So a lot of people talk about breaking dentures or wearing down teeth or wearing dentures or cracking ceramic. Zirconia is the strongest material we've ever had. Monolithic zirconia can be stained. It'll last longer. It'll look beautiful. It doesn't lose its color. A lot of people say, I used to have it. It used to look whiter. It lost its luster. It got stained. Polished zirconia will look at the same 10 years later, 20 years later. So make sure you go to a full operational office, a good team. It does take a team. Great hygienist going to help you keep your full arch of implants and your prosthesis in the mouth for hopefully your lifetime. You can't afford to do it wrong. So if it costs a few extra dollars to go to a more reputable or well-known or experienced team, I think it's worthwhile.
And just the cherry on top of that, that Dr. Salama said so well, but the cherry on top in the interview we did today with Byron, it really was talked about your gut. Trust your gut. Do you feel, don't ever be intimidated, because it's intimidating. I mean, you're one of the most vulnerable positions sitting in this chair. I get it, but there's a gut feel. Do you trust? Just like Byron said, when he came in here, he only went to one location. And so for him, he trusted his gut, and you saw the smile and the outcome, and it went fantastic. And now we're hearing why it went so well. But he didn't know all this. So your gut will not lie to you. Do not be scared of that. Trust yourself, because if you've done all your homework, make sure I'm not saying just go in and, trust your gut without doing any homework. Know all these things, but you can have 4 clinicians that might meet all those parameters. Trust your gut, please, because it's going to be a relationship. This is not something like a filling where you come in and you're gone and you're done. I mean, this is, you get to know your patients on a long-term basis.
For sure.
Right?
Absolutely, absolutely. It is a maintenance thing. You need to make sure you come in and see us. We check everything, make sure everything's right. But I want to just mention one last thing, and then
Okay.
because this is also very important. You've heard the term when you're a hammer, everything looks like a nail, right? So there's a lot of dental practices out there that try to say they're all on X centers. I don't know who they are, but there's some out there. We'll leave it at that.
All right.
And you may even see commercials where people just talk about that's what they do. That's all they do. I want you to be very careful of that, because there have been cases that I have seen as a second or third consult who have been told that their teeth are not worth keeping, that they all should be removed. And I have seen that not to be true, where some of the teeth are very, very salvageable, and you can build a whole set of new teeth, what I call not all on X, but all on teeth, where you can build a bridge on the remaining number of healthy teeth that can be salvaged. So think about the difference between renovating a home or knocking it down and building from scratch. Your home may not need to be knocked down. You may be able to salvage enough of the house where you can just renovate it. Don't just believe a person if that's all they do is implants, then that's all that you'll receive as a treatment option. In our office, Goldstein Dr Salama have been around since, as I said before, this office since 1929, but I've been here since 1992. We do the full gamut of dentistry. We treat teeth as well as implants. And if your teeth are worth keeping and you understand that you have options, at least you have options. You may decide not to keep the teeth, but if you're at least told that your teeth are capable of supporting a full bridge, it may give you another 10 or 20 years before you then need implants. Something to really, food for thought.
No, it is. And I appreciate you bringing up that fact, because like I said, I've gone to some consultations where you're right. It's almost like a mill. It's, okay, this is all we do, so this is all we're going to offer.
Correct.
And
assembly line, cookie cutter.
Instead of having the guts and the selflessness to say, you know what, I really think, even though this is all we do, you might want to go see a periodontist. You might want to go see a good general dentist to see what they can do for this, instead of, and that's, you guys hold a lot of power. I don't know, I think you know this, but, and maybe that's one reason, not saying you, but one reason why so many dentists might be so ego driven. I've seen a lot of that, right? And yet the power that they hold is so strong, because you take a patient and you guys can make or break us.
Right.
You can.
Yes.
You can make, I'm in the executive world. I do a lot of speaking. I do a lot of that. You jack my mouth up, you just not only ruin my confidence, but even my career and my livelihood, right?
Well, there's no doubt that we can do that. We can harm people. We can harm them, debilitate them. There's an equally important thing to understand about planning, the planning phase of this treatment, what people may not know. And another, I think, important thing. So number one, you may not need to lose your teeth. But let's say they say, that you believe and they say you can't keep your teeth. Yeah. The reason the planning is so important is because in order to be able to put the all on X in, you need space for the prosthesis, because if it's too thin, it's weakened and it breaks. So very often we are forced to not only remove the teeth, but to remove some of the bone.
Sure.
So if it's not planned, it's being done arbitrarily. What does that mean? The doctor goes in and it's not guided. He didn't plan it. He just goes in and kind of eyeballs it. He just takes down your bone. Well, once he takes down that bone, it's gone forever. It's not coming back.
Right.
So if I always tell people, God forbid, if you had small cancerous growth in your body, I want that doctor to use whatever technology they have to remove only the amount of diseased cancerous tissue that needs to be removed, and not a millimeter more than that.
It's a great point.
Yet in all on X therapy, you will go to places where if they need 5 millimeters, just to be safe, they'll take away 10, so they won't guide it. And what we're going to talk about with Dr. Tadros is how we use computer-guided surgery to make sure we only remove the absolute minimum amount of healthy bone and tissue that is necessary for the procedure.
That's such a great point. You know what I would like to ask, and we'll just see how things go. We need to do this again because I feel like there's so much more that you guys have in your education belt. But the fact that you took time now and for this, I really appreciate
my pleasure.
you doing that. Let's go see Dr.
Yes, let's
Tadros
get
and go
Dr.
see the
Tadros in.
lab.